Ladies and gentlemen, welcome to today's Supportive Care Coalition webinar. Today's presentation is titled Palliative Care and Hospice Collaboration, Frontline Care for Patients with COVID-19, presented by Dr. Kara Jennings, Dr. Mark Flickinger, and Ann Hardy. Before we get started, I'd like to mention that today's session is being recorded and you are currently in a listen-only mode. You will be receiving an email tomorrow with access to the recording to listen to on demand. A large portion of today's webinar will be a question and answer period, so please use the questions panel on the right side of your screen to begin submitting questions at any time for our speakers to discuss. If you experience any technical difficulties during today's webinar, you can click the Help tab at the top of your control panel or ask me a question directly in the questions panel. Now, without further delay, it is my pleasure to introduce your moderator for today, Denise Hess, the Executive Director of the Supportive Care Coalition.
Thank you, Brianne, and welcome everyone to today's Supportive Care Coalition webinar. For those of you learning about the Supportive Care Coalition for the first time, the coalition is a partnership of Catholic healthcare ministries from across the U.S. dedicated to advancing excellence in palliative care through ongoing advocacy efforts at the local and national levels, through interprofessional education, resources in healthcare ethics, and the integration of spirituality in palliative care practice. Coalition members have complimentary access to monthly webinars, numerous resources on our website, and a community of like-minded learners from all disciplines represented in palliative care. Today, we are excited to continue our latest series, Navigating New Realities, Best Practices in Palliative Care During COVID-19. This series highlights the work of palliative care clinicians from across the U.S. who are adapting and innovating in the face of the pandemic. These sessions will spend about 30 minutes discussing new challenges faced in palliative care, solutions that worked well, and key takeaways, followed by about 30 minutes or so for Q&A. As Brianne mentioned, you can begin typing in your questions for our presenters at any time during today's presentation. So today we are welcoming Dr. Kara Jennings, Dr. Mark Flickinger, and Ann Hardy, members of the Bon Secours Mercy Health Richmond Palliative Care Team. Dr. Jennings is a palliative care physician and a licensed medical acupuncturist and is board certified in physical medicine and rehabilitation and hospice and palliative medicine. She joined the Bon Secours Mercy Health Palliative Medicine team in 2013. Dr. Flickinger holds board certifications in family medicine and hospice and palliative medicine. He joined the Bon Secours Mercy Health Palliative Medicine team in March 2016. Ann Hardy is a licensed registered nurse certified in hospice and palliative care through the Hospice and Palliative Care Nurses Association, and she joined Bon Secours Mercy Health Hospice team in 2018 and currently works on the clinical liaison team serving patients, families, and staff in all Bon Secours Mercy Health acute care facilities in the Richmond market. And so, without further delay, I will turn it over to you three. Welcome. Thank you so much for joining us. Happy to have you here today.
Thank you so much, Denise and Brianne, and thank you to the Supportive Care Coalition as a whole for delivering excellent education, especially during the pandemic. We watched quite a few of these webinars in this series already, learned a lot. A lot of great information has been shared, so hopefully we can also share some good information with you today. So before we get started talking about our palliative care and hospice collaboration, frontline care for patients with COVID-19, we just wanted to take a few moments for a reflection. So Ann?
Good afternoon. I thought we could get started with a little inspiration from American author and poet Maya Angelou. Each one of us has lived through some devastation, some loneliness, some weather superstorm or spiritual superstorm. When we look at each other, we must say, I understand. I understand how you feel, because I've been there myself. We must support each other and empathize with each other, because each of us is more alike than we are unalike.
Thank you, Ann. So as Denise said, we're with Bon Secours Mercy Health in Richmond, Virginia. Bon Secours merged with Mercy Health about 2 years ago. And so now our ministry extends from up and down the Atlantic coast, as well as Ohio and Kentucky. And we are in the Richmond market. So there are 7 hospitals, 4 hospitals in the main Richmond area. The other 3 were kind of acquired recently and are in the southeast of Richmond. Palliative medicine and hospice has not yet expanded to those hospitals. We're lucky to have a really robust team here, very well integrated into the health system and medical group. So we have palliative medicine inpatients and outpatients, hospice at home and inpatients, palliative home-based clinic, and then home-based primary care as well. So together we share similar patients, although we are separate, but we share call responsibilities on the weekends. So but for today's focus, we're going to be talking about the inpatient teams for palliative hospice only, and really our experience during the pandemic, which in the Richmond area started about late March. Our inpatient palliative team has 3.5 FTE physicians, 5 NPs, 3 social workers, 1 chaplain, but really close chaplain integration at all of our sites. So to get a sense of our program, you can see on the graph over here to the right, our inpatient palliative consult volumes that start in the beginning of 2019 until July of this year. So for example, St. Mary's Hospital in the green, we saw about 125 new consults last month, in addition to all of our follow-ups. And then at the bottom of the slide, so you can get a sense of how many COVID-19 patients we've seen, you see at St. Mary's Hospital, 233, St. Francis, 133, and Memorial Regional, 202. So that was at the end of March until last week, the number of patients.
And my name, once again, is Mark Flickinger, and in February, I became the medical director of Bon Secours Hospice here locally. And this describes a little bit on this slide kind of what our team encompasses. We have 2.5 full-time physicians, but we also have a full-time nurse practitioner. We have 5 liaison RNs, and just to kind of explain their role, they serve as our eyes and ears in the hospitals. They take on new consults, arrange for patients to go home. In addition, if we have inpatient patients within the hospitals, which we can do GIP or inpatient level care in the Bon Secours hospitals, they are the ones that oversee that and make sure that patients are taken care of, along with the bedside nurses. We cover all 4 hospitals in the Richmond area, as well as we have a community hospice house. Just to explain the hospice house, it is a short-term type of facility, typically for GIP, kind of inpatient level of care, 16 beds, all private rooms. You can see at the bottom of this slide the picture of the hospice house. This is a unique thing that we have here in the Richmond area, in the Richmond market, which allows our patients to be discharged from the hospital to that facility for ongoing care. We also use the facility often for our respite patients. In addition to that, the hospice house has contracted with other local hospice agencies that they also can use that facility for their GIP and or respite patients. This, the next part of the slide talks about our kind of GIP and kind of level of cares. This does not include the community hospice house. From September to August, we had 237 inpatient level of care patients, and we had 106 other consults who actually passed before we could even get them admitted to the hospital or get them home. Next slide.
So these are some of the challenges that we faced as the pandemic started, and certainly other areas have been hit by the pandemic at different times. Like I mentioned, ours was end of March. So we faced a more critically ill patient population. And Dr. Rodden on the webinar with the SCC a couple weeks ago hit upon this, is that there were different populations than we're typically used to seeing in palliative and hospice medicine. We're used to seeing oncology patients, elderly patients, those with serious chronic illness. These were different. These might be younger patients without any comorbidities. They were also sicker. So we're used to seeing patients on the ventilator for 1-2 weeks. We now have patients who are on the ventilator and come off after 2, 3, 4 weeks, We have some patients on the ventilator for months. So just a different set of patients, but all very sick the same. We also face limited personal protective equipment and other resources. So this was in March, and things have gotten better. Remember back then, though, there was a shortage of even regular face masks. What we were working with was hydroxychloroquine, zinc, vitamin C, and that's all. So while there's still a lot of room for improvement and growth that's happening every day, it's still a challenge that we face.
So from the very beginning, all the Bon Secours Mercy Health facilities implemented very strict no visitation policies. And that applied to all inpatients and for any patients visiting the emergency department. So as you can imagine, this made getting hospice consent and other important family discussions very challenging. Some of those policies have relaxed a little bit as we move forward, but certainly at the beginning, this is really one of the most difficult challenges I think we faced in trying to get families in, and to also have to look at patients going through this experience without the support of their loved ones. And as the health system ramped up their preparation for the expected surge of COVID-19 patients, we began to see COVID-19 units popping up on units where restorative care had previously been provided. So think joint replacement and other elective orthopedic procedures. So these staff now whose clinical focus is primarily to get their patients back to full functioning and to restore them are now faced with providing critical care and end-of-life care. So we'll talk a little bit later about how we met those challenges.
And finally, two other challenges that we faced. These patients come into the emergency room tend to be sick, fairly sick early, or decompensate fairly quickly. And I think that the problem was without the visitation, where the visitation policy was, we struggled with advanced care planning and having those discussions. Typically, of course, the palliative team, that's what we do, have these discussions with families, in the room typically, with the family present and the patient present and involved. But without the family there, this made it very challenging. A lot of these discussions, unfortunately, were having to be done via phone. In addition, some of our case managers in the ED were trying to have discussions outside the room with the patient in the room who was COVID to try to limit their exposure as well as PPE. And so this kind of became very difficult. We'll talk about what we enacted later in these slides, but this certainly presented a significant challenge and a change in how we had to look at advanced care planning. And I'm hoping in the future, advanced care planning hopefully be more addressed in the outpatient setting prior to patients coming to the emergency room critically ill. The other thing that we faced early part of April, we had a patient go to the hospice house for respite because the family member had fallen and was ill. Unfortunately, a family member that was a caregiver ultimately had COVID, which we did not know. This subsequently, the patient that was there respite ultimately tested positive as well and essentially exposed our whole staff at the hospice house. So they all had to be quarantined. We basically had to close the hospice house because we didn't have staff to actually man it. And then as elective surgeries went away, the hospital census went down significantly. So administration elected to keep the hospice house closed since that was one other area that we could limit exposure as well as conserve on PPE. And so all of our inpatient care for hospice patients was essentially done in all the hospitals, and we'll talk a little bit further about that as well.
Okay, so we'll start to talk about some of our solutions that we recognized. We had early engagement with hospital leadership. So all of us really met early on with the hospital CMOs, the leadership of the emergency department, ICU, the hospitalists, and how we could help during this time while focusing on advancements, treating these COVID-19 patients, but also making sure that end-of-life patient care for these patients was not forgotten. We were able to learn from other hospital systems. So remember early on, New York, Washington State were hit early, hit hard. So one of our colleagues, actually our old medical director, Dr. Yanni, who is now in population health as clinical director, was able to speak with Dr. Diane Meyer and Dr. Sean Morrison at Mount Sinai. And there have been many good podcasts and webinars, but this one in particular was very helpful early on. It was a podcast with Dr. Daryl Owens from the University of Washington. So what they learned is that at first they wanted to train all these frontline providers in the ED and the ICU how to have end-of-life conversations, how to have goals of care conversations. What they realized is that the influx of patients was too fast, and they actually had to step up and become the frontline. And so they embedded themselves in the ICU, in the emergency departments for 24/7 actually to begin with. And so learning from this, we recognized that we needed to be more present in our hospitals to provide comfort care for end-of-life patients, especially those who were COVID-19.
So we did as a team, I think early in this, both the palliative and the hospice team came together. And I will say we had some tough discussions early on in this because we essentially had to ask everybody who's in and who's out, because we needed to know who was going to be with us as we go forward, because we knew what was potentially coming based on some of these other discussions with other facilities. And there were some people that opted out and elected not to proceed further with the teams. But the good part is that we had great collaboration. The leadership at all the facilities and the hospitals were open to our palliative and hospice teams being intimately involved early on, and frankly accepted all the plans that we brought to them without any significant pushback or anything. And so these discussions included both the ED physicians, the hospitalists, and essentially what we became was, instead of a consult service, we became attendings for the end-of-life patients. So this did a couple things. It allowed us to kind of have some control over making sure patients were comfortable, symptoms were managed. And in addition to that, it kind of freed the hospitalists up to be able to kind of do their job on other patients that maybe they needed certainly more time with. And in addition to that, it also allowed us to have multiple discussions with families. We often did a lot as the attending. We would go in the room towards the end of life, because visitation in the beginning was still not allowed at the end of life, and essentially do Zoom calls or webinars or however we could get the family members on the line so that they could see their loved ones at the end of life and provide those symptom management.
So as attendings, we had direct admissions for end-of-life patients to our palliative service as comfort patients. And during the daytime, we admitted directly from 8 a.m. to 5 p.m. And on another slide, we'll kind of talk about why we did not do direct admission in the evenings. And then we had one of our physicians who actually met the health requirements to work from home. And so for about 10, 12 weeks, she worked from home. And this actually worked out to our favor, because she was the direct point of contact for the emergency department 24/7. And so they were able to reach out to her to have family goals of care conversations, to help direct them towards symptom management or goals of care conversations themselves. And then because this was different than being a consultant service, we had to round on all of our patients who we were attendings for comfort patients, in addition to GIP hospice patients and multiple different locations. We actually had physicians volunteer for extra call to make sure that we had enough coverage on the weekends.
So we get into, I guess, mid-March, and now that we are sort of merged in, when I say we, I mean the inpatient hospice team, the liaison team, we are now pretty much merged with the palliative inpatient team. And we still had some hospice consults for people wanting to go home who were not COVID positive. So we had some of that work to do, but primarily we were focused on now going into these COVID units that we described in an earlier slide. And the more we went there, we frequently saw poorly managed symptoms. And we realized this was not a matter of negligence on the nursing staff, but rather it was more of a lack of education and confidence, and some skills and abilities on the part of these nurses who, as I mentioned before, were used to practicing through the lens of restorative care and getting these patients back to full functioning. And as we talked to them and explored the reasons why they were so uncomfortable, we found out that many of these nurses had never seen a patient die on their watch. Some nurses and techs had never done postmortem care, things that we tend to take for granted in our roles in palliative care. These were overwhelming experiences for these staff members. So it was quite satisfying, really, to know that we really did have an important role in making this a better experience, not only for our patients in helping control symptoms or identifying symptoms first, then controlling them, but to really shepherd the staff, if you will, along along the learning curve in providing this end-of-life care. Dr. Flickinger mentioned earlier that when the hospice house closed, they redeployed a lot of the community hospice house staff, and we, the liaison team, were fortunate enough to receive a couple of those nurses who have now become an integrated part of our team, and I'm going to be really sad when they leave. But they, being bedside nurses, were allowed to actually give some hands-on bedside care in a couple of our facilities, given Pyxis access. So they were really an augmented staff for the bedside nurses. And then we, as the liaisons, continue to, in our role as eyes and ears for the palliative doctors during the week and especially on the weekends. And then finally, assistance with family communication was another area that the nurses and other staff members on these units identified as an area that they were very uncomfortable working in. So we took on a lot of that. We did a lot of family meetings by Zoom at the bedside, took care of a lot of the end-of-life and treatment goal planning with families so that they did not have to take that on.
So what we found is, in our experience, at least inpatient end-of-life conversations really had to be held in person. And this held true even when there were more virtual platforms like DoxyMe and Zoom became more available. Certainly a lot of the conversations with family members, especially given visitor restrictions, were held over those platforms. But we had a lot of them at the bedside with the patient if the patient were able to talk and have conversation all together. We found that most effective. At the same time, we did want to limit potential exposure, be safe. So inpatient providers, meaning NPs and physicians, do see all COVID-19 patients and PUI or rule-outs. PUI is patient under investigation is what we call here, and that's been the case since day one. Inpatient social workers, however, do not see COVID-19 patients in person, but they are in the hospital for other consultations and then to help with bereavement and other issues for family members or patients over the phone. And our chaplains actually do not fall under the palliative medicine departments completely, although we're linked, they fall under pastoral care. So their directive from the beginning is that they do not see COVID-19 patients in the room. However, I feel that really all of us have risen to the occasion. And so, for example, we've had compassionate extubations in the ICU, where spiritual assessment was very important to families. And they wanted to actually see the patient during the compassionate extubation. So the chaplain would join a Zoom call with the family, and then they would be all able to see the patient in the room for end-of-life care, and the chaplain was able to share prayer over the Zoom call. And that's just one example of many.
We'll talk a little bit more here about advanced care planning. We had talked about one of the challenges with this early on. We do, Dr. Leanne Yanni, who's a clinical director of population health, and Rebecca Kruskas, who also assists and is a clinical operations specialist with population health, both enacted kind of a program to start across all Bon Secours Mercy. And this program was enacted to kind of build up and have discussions about advanced care planning early on. What they ended up doing is identifying what we identified as advanced care planning activators, and care managers for any patients with COVID-19 or a rule-out. Honestly, the most of these were the case managers on the floors of the hospital, where these activators were having some discussions that they typically would not have done in the past. But our palliative medicine social workers actually were the ones that educated the activators, because that's once again, that's what we do on a regular basis. And so, for instance, I can tell you where I was at St. Francis, Melissa, our social worker there, each day would look at the list, and we'd know who was COVID-19 or a PUI, and we would make sure every single one of those patients had a note on that talked about advanced care planning. And often some of these were a little bit complicated, and anything that was looked a little bit complicated or complex, or it was unclear who exactly the medical POA may be, then that's where palliative would get more involved to just make sure that we identify who we're going to be talking to if this patient were to become more critically ill and unable to speak for themselves. As you can imagine, this gets a little bit complicated because family dynamics can be challenging at best sometimes, and so often this meant multiple different discussions with multiple different family members to make sure we knew who to go to if we needed to. So I think this down the road is something I think hopefully that we can actually continue. And once again, I'm hoping even that we can backtrack it a little further, that where a lot of these discussions are hopefully had in the offices before people show up to the hospital very sick. And I think we've already seen some of this with some of the primary care providers having a lot more of these discussions with family members, even virtually through this time period where they maybe weren't able to get patients into the office. This is something they can actually do virtually very simply. And so I think hopefully this will be something that will continue in the future as well.
So getting into some of our plus delta, there were a lot of pluses, but just during this difficult time, actually. But focusing on the fact that hospital leadership was very receptive and thankful for our response. Dr. Flickinger kind of mentioned that the administration really took all of our insight and inputs and was grateful for our thoughts as frontline providers on the forefront of the pandemic. The other thing we found was that our hospice liaisons, the nurses were very clinically strong. So palliative medicine and hospice were obviously integrated, even though we're separate programs. But I think this pandemic brought us all much closer and to show us how we can work better together. And the integration was really necessary to care for end-of-life COVID-19 patients. Remember that on the weekend, we had 1 and then 2 providers to cover multiple different sites. And those people were covering all the home calls from home hospice, our office calls, inpatient hospice, and then these comfort patients as attendings. So our hospice assessments by our nurses were really important when we couldn't maybe physically be there in time. Some things that we could learn more about. So we attempted to limit inpatient team exposure. And as I mentioned before, overall for our team, we just did not find that would work very well. We also found that we cannot admit overnight over the phone. And this was a learning process because we were never attendings before. We were always a consult service. So at the beginning of this, our physician at home did a wonderful family meeting in great detail, collaborated with the emergency room department to help with all medications as needed, and admitted a patient to our service for end-of-life care, COVID-19, under comfort measures. That patient passed away before we were able to assess them in the morning. So the regulations for being an attending as a palliative medicine doctor versus the hospice regulations, which are very different than other specialties, meant that we really did need to kind of do a physical exam. So from then on, in the evening time, we actually had the hospitalist admit, and then in the morning we would take over. Mark mentioned our wonderful ACP activator conversations and program, which is only going to continue to grow. So you actually have in our handouts, you have our templates that we have in our Connect Care Epic. And you can see that its purpose is to be concise and streamlined. These conversations are being held in the emergency room, over the phone, potentially when a patient could be crashing pretty quickly, just so we have something documented. And that's very important. At the same time, we learned that maybe there's room to expand on these conversations if the patient isn't, declining so quickly. Because at times it's more difficult if a conversation's already held, but maybe it could be done in a better way, to kind of go back and undo that conversation and redo it again. But we're all learning together. One other thing that we learned by our legal team, at least in our health system, is that when the ACP activator wrote down a name, typed down a name of the healthcare agent name verbally in the emergency room, it really needed to be backed up by an advanced medical directive written. Usually that would be the case, but in certain instances when it wasn't written down, we actually had to go by the legal next of kin. Once again, we're all learning together, and one good thing about, one of the many good things about the ACP Activator program is that they notice palliative needs sooner than maybe by the attending physician, so that palliative is consulted earlier on.
So I think some takeaways and some things that we noticed as we got into this after several months is that extra call for physicians and rounding as attendings on the weekend, really not sustainable for a prolonged period, given the limited number of providers that we have. We certainly could do this for a couple months. And I can speak personally. I took a week off last week for the first week off since the middle of March. And I'm telling you, I was limping home to get to my vacation. And so I think it's not something that we can probably do for a long period of time. But if things got bad again in the winter, or we have a second surge here, I do think it's something that we could do at least in a short amount of time. And at least we've been through it once, so we know kind of what it's going to look like. And I think part of the problem early on in this is we didn't know what was coming. We saw what other places were getting across the country, and so we had kind of ramped everything up, prepared for the worst. But I do think it's something now that we know we can do, at least for a short amount of time, and certainly leadership has been on board with this as well. And I think the other thing is this, this is taxing. Let's just be honest. For palliative and hospice is kind of an emotionally taxing job anyway, but this has been taxing on our team. And because these are emotional conversations, people dying without loved ones at the bedside, that's not what we do typically. And so that has been very challenging for all of us, and seeing that, but I do think we all stepped up as a team to make sure at least the best we could do is have family members present, even if it's via phone, or if it was present by Zoom, somehow to make sure that they were involved or knew that they could see their loved ones at the end of life.
So in closing, I would echo what Dr. Flickinger just said, that it has been taxing, it's been challenging, but I think overall we're very grateful for the experience. As he said, this has brought a lot of us together. We've seen how we can work together in ways that we had not previously had tried. And I know for the liaison team, we've enjoyed the changes that we've seen at the bedside. There's a greater awareness of end-of-life care. We are continuing ongoing education with the nurses who provide our GIP care across the hospital. And, I think we're seen more now as collaborators instead of just visitors on a unit, which I think is progress that we can build on. And, we're all better prepared for what may come in the future, because, we never know when a COVID unit may pop up.
Thank you all very much for having us today.
Thank you.
Thanks.
Thank you all for just such an informative and engaging, really peek behind the curtain of your really well-established program, but the ways you pivoted and maximized the collaborative relationships you had spent years cultivating, I'm sure, is very impressive. And so I would invite all of our audience members, as you have already been doing, is to navigate over to the questions panel and type in your questions, comments for our presenters. Already there are a lot of thank yous coming in, echoing our thank yous to you too, just for sharing. It's so important for teams to be able to learn from each other, as you all did in the very beginning when you reached out to Mount Sinai and others. First question, kind of backing up a little bit, can you give us some background about how it came to be that your palliative inpatient program and your hospice programs are so closely aligned? Because that's not the case in many people's situations across the country.
Well, I think I joined this program in 2016, and I think soon after joining the palliative program, once again, it was initially a palliative provider. Part of that was the leadership of Dr. Yanni, who was the leader of our group, and bringing hospice and palliative together. Plus, quite frankly, a couple of years ago, there was a need. Their hospice was struggling for a little while a couple of years ago, Bon Secours Hospice, and there was a need for help. So it was a combination of things, I think, from leadership plus the need. And now we're integrated now almost. It's hard to tell the difference sometimes between all of us. But now I think it's kind of one of those things, particularly with what's happened with COVID. Although Kara may want to separate from us, it may be hard to separate us now going forward. So.
Kara or Ann, did you have anything? Yeah, to share? Yeah, go ahead.
I've been here since 2013, and before I got here, the hospice and palliative programs were actually together and separated, and they've kind of come together and got apart through the years. But I think at this point, we really came together because there was a need, right? We all came together to do what we do best, is take care of patients. And so there was a question, and I think that helped us build kind of a good rapport working together, and like Anne commented on, being collaborators together at the bedside along with everybody else rather than visitors or somebody on the outside.
I don't really have much to add. I've been here since 2018. Had worked with in hospices outside of the Bon Secours system, so this is my first experience being in a health system, and I can just say that it's been a wonderful experience. And because I work in the inpatient setting all the time, you know, the palliative team really it's an extension. I mean, I feel like we're first cousins, first kissing cousins, I guess. So.
That's excellent. It's unique, and as I said, you all really leaned into the strength of that collaboration to do something unique for your patients. And I'm going to start with you on this next question because it comes from one of the nurses listening today. And this nurse is curious about the role of nurses in advanced care planning conversations. Is that something that nurses in this integrated team are typically involved in? And I guess then for Mark and Kara, following up to that, in this ACP collaborative rollout and ramp up, how did you all facilitate all the disciplines in palliative care working at the top of their license?
Well, yes, we do have nurses involved in the ACP discussions. There is it's not really a certification, but there is training that needs to be completed before you can actually participate as an ACP, you know, provider. Certainly, we do talk about DD&Rs and that type of thing on a regular basis as a liaison, but for filling out advanced care planning, that is left to nurses who have had special training.
Sure. And on our palliative medicine team, so on the outpatient side, we have nurses who do advanced care planning. On the inpatient side, we actually don't have an RN on our specific core team, but our social workers and actually our chaplains all throughout the system, the healthcare ministry, have been actually trained with honoring choices or other teaching programs. So they are able to complete advanced medical directives. I think the difference that we're seeing now is that more primary care offices are doing them, and then also the care managers, when they are kind of in a role as ACP activators. They previously had not been doing advanced care planning. Now they are able to do that.
Yeah, I don't have much to add. I think that I certainly think our social workers played an integral role in how this worked over the last 5 to 6 months. And getting everybody up and educated that needed to be educated on how to do these, particularly the case managers and even other staff, the chaplain staff and other things. So they definitely irreplaceable during these last 5 to 6 months with that.
And then Denise, just something simple that we've learned here. You know, if there's remember I said that if we document it on the computer that somebody names a healthcare agent, it doesn't necessarily take effect. So we want to do that advanced medical directive as well, which sometimes can prove just more time consuming when they have COVID-19. Kind of the policy here is that we do the document inside the room, but then have somebody outside the room with plastic sleeves, which is very simple, you know, dropping in the documents in the plastic sleeves, taking them, recleaning them, making copies of them, and putting them on the chart. So it's not rocket science, it's pretty simple, but it does take more time. And so we just need to say, you know what, this might take 15 extra minutes, but it's important, we need to do it.
Yeah, some tricky legal requirements you all needed to, I'm guessing, first clarify and then change your practice around. Yeah, commonly that's happening in many systems too that we've been hearing from. The next question is about this very real issue of sustainability that you have raised. So you stepped in, you became attendings, you learned about the challenges of trying to admit overnight or not. Your team is not of the size that this is sustainable. The question is about how did you, kind of extract yourself, right? I'm sure you came to be very valued to the hospitalists and others who you were basically unburdening from some of this care. So how did that whole backing out happen?
Slowly.
It was a process. So early on, we said that, well, there's a need. We typically wanted to off-burden the hospitalists. We were prepared for a big surge. We're not the size of New York, but we were planning for something like New York to happen here, right? We were planning that we might run out of ventilators. I was on the surge committee at one of the hospitals. So that's when we really said we need to be attending for these patients. We don't have PPE. Why are we having 2 teams go in when it's end-of-life care, which we can manage on our own? So once we kind of found out what I don't like the term new normal, but the new normal is going to be at least, and things kind of settled down, we had open conversations with, once again, the same leadership that we had the first conversations with, and said that, long-term, this is not sustainable. And also, we're not sure if it's needed at this point because we had that collaboration role. So attendings felt more comfortable, for example, even going to Anne and saying, what do I do here for this end of life? Is this inpatient hospice? Is this a home hospice? What do you think? And so it was actually kind of a gradual process. There was no big extraction necessarily.
I don't even think there was necessarily like this formal discussion like, hey, June 1, we're out.
Yeah.
Something like that.
There was a different hospitals too, different needs.
Yeah.
I
agree. It's more of a gradual kind of thing and I think the other thing is the hospitals started getting back to quote normal, which means started doing elective procedures, starting doing the things that they've done in the past. And so kind of all processes kind of, I don't want to say went back to the way they were pre-COVID, because I don't think it's ever going to go quite back to that, but things started getting more normalized. So, and we also got better in our hospice processes with the ability to get signatures for inpatient level of care, these things called DocuSign. And so once we were able to get that, then we could kind of go back to the way we used to do it. We had a minimum GIP under hospice, and then our hospice attendings would take over. And so I think this kind of gradually kind of flowed in that direction as other things normalized.
That's a good point, Mark. Another thing, too, is that our visitor regulations have loosened, like so many other places. So early on, there were no visitors, even end of life, active dying, there were no visitors at all, and that has changed. And so, once again, just getting back to kind of maybe a new baseline, but we're also prepared for what if that next surge happens. People are talking about this fall, this winter with regular flu season coming on. We're already seeing some different units. For example, we have adults now in our pediatrics unit. So in the back of our minds, we are ready to go back into being a more active role as attendings if needed. But I think early on, I don't really think we were all gung-ho. Once again, referring back to Dr. Rodden's presentation on August 4th, remember at first she kind of had a grasp, and she said at first she felt like, this is amazing, this is what I was trained for, I'm ready to do this, and just went in head first. And it was after a little while they were like, my goodness, I don't think we could do this for forever. So we recognize that now. And I think if we had to go back in that role, we would have maybe a more specific, defined period of time in which we would do that.
And how about in your role? It shifted quite a bit as a liaison. I mean, there was much overlap, but things changed. How do you see the role of yourself and the other liaisons going forward?
Well, I think that, as I mentioned before, we're much better prepared. We're not going to have to reinvent the wheel. Getting consent was a huge issue at the onset. And as we just mentioned, a DocuSign, I remember I kept begging for that pre-COVID. And then be careful what you wish for, right? So we have DocuSign now. It's not as easy as I thought, but so we have that now. That's definitely helped our processes and lifted some of the pressure. A lot of our families are either COVID positive themselves or they're at high risk, and they're really fearful of coming into the hospital, even though the restrictions have been listed and they can. So it's really nice to be able to offer that. However, obviously not everybody has email. But at least that piece is taken care of. I think we know we have the palliative team has our back and we have theirs. So again, not reinventing the wheel. And I think moving forward, it would just be, and less fear of the unknown makes everybody, a lot easier on everybody.
I think one of the handouts Caissons came up with is this kind of a symptom management cheat sheet that they did for the nurses that were in these joint units that had never taken care of patients in these kind of situations. So I think that was very helpful for the nursing staff, that if we could, we're not there 24/7, and so at least knows what meds to give, what symptoms they're looking for, try to help educate as much as we could.
Yeah, and we're actually using that now. That was one of the positive fallouts of this, is that we're using those educational tools now across the hospitals. We've scratched out the taking care of the COVID patient, and because it applies, it's like a layperson's guide to giving end-of-life care symptom management.
Yeah, and thanks. You led into the next question, which was, could you say a little bit more about how you rolled that out? Was it kind of a just-in-time, here's a resource we developed, just handing it out person by person, or was there a more formal educational structure?
Well, I think it was as we were going on to the COVID units and seeing more and more patients who had poorly managed symptoms, and not feeling like we can't be in every room with every nurse all the time. And so not wanting to offend anybody, but talking to nurse managers about what can we do here, what would be the most effective educational intervention for your nurses. And that was brought up, if you have any written materials or any posters. So that was the catalyst for that. And it was well received. Every nurse could have one. We wanted to put it on like a little laminated thing. We haven't gotten that fancy yet. But I think all of the units and all of the hospitals have used it.
That's fantastic. That's really great. And thank you for sharing it. The folks who are on today, just make sure and check your handouts tab. I see some folks asking about it. Should be in their handouts tab. If not, feel free to email us, email Brianne Cedar-Green, and she can send them to you. So I want to go back to something you said, Mark, where you talked about that, I think you said you were limping to your vacation recently, and that the word you used was that this whole experience was very taxing. And I think that's something that almost all palliative care and hospice clinicians have experienced or are experiencing, is just a very increased level of stress, accumulative grief that's happening. As you said, we're used to having difficult conversations and being present to sadness and suffering, but this is at a much more heightened level. Any things you all are doing as a team, individually, to address the heightened stress and grief?
Yeah, I think individually, I think we all kind of have our things that we do to try to get away if we can. I think the hard part about this, though, is you can't get away from it. You go to the grocery store, people are wearing masks. You're like, dang it, I can't get away from this. It's there all the time. You turn the TV on, it's there all the time. At least in the past, there's ways we could kind of at least not have to worry about it, or what we were doing. But at this point, there's no escaping kind of what's going on in the country. And so it just is a gentle reminder every day kind of what we're doing and what we're in. And I think, for me, it's great. I got a loving family. I got a great wife. She kind of supports me and knows maybe what days are good and what days are not so good, and knows kind of when to kind of step in and those kind of things. I think we try to take care of ourselves as far as exercise and doing the things, getting outside when we can. I do worry a little bit with the winter coming up. This happened in the spring. And so, people at least still were able to get outside some. The weather wasn't terrible. I do worry if this we get a second surge, kind of the winter, it's dark, how people can kind of get outside and be able to do some things. It's going to be a bit more challenging going forward. I think from a hospice side of things, we did try to do a few things. I don't know what that thing was called that we did, Ann, where we had like this car court kind of thing where people could drive, or all the staff came to the hospice
Appreciation
Day, and we were all in our mask, and all the leadership was in our mask, kind of giving things and appreciating everything they were doing, because it's been challenging for our home team as well, and quite frankly, they're probably at increased risk than we are in the hospital, because they're walking into a lot of unknown. Who's in and out of those houses, you have no idea who may be COVID and who not. So it's been very taxing on our home team, and being able to get into these homes, which is with a lot more unknowns. At least in the hospital, you know who's COVID and who's not, essentially, and so you know where to protect yourself as best you can. And so I think trying to do those little things to try to take care of your staff, make sure they know we appreciate them, I think was really important.
One thing that we've been doing from an inpatient side too is trying to utilize our paid time off, our PTO. Sometimes you just kind of forget about it. It took Mark multiple months to use the week off, but to remind you that it's there and use it, and that if maybe if we're a little short staffed one day, that's okay. We'll work harder so that one person can take off. Or if we're noticing that one person is kind of having a hard time, you know your team well, right? You can tell it even if they're not verbalizing. Just go home early that day, but I'll cover the slack, and you get on my back the next day. One thing that the hospital staff is doing, that because we're focusing on this webinar about end of life, particularly those that end of life with COVID-19, but we also had success stories. I've had success stories of patients that I thought would not make it. And so when those patients actually leave the hospital, whether it's home or to rehab or wherever they're going, we kind of all line up and just try to kind of cheer them on. And celebrate that what they've overcome.
Lovely. Anne, would you like to have the last word on that question about stress and grief?
Well, echo the same things that Kara and Mark have said. Taking care of, self-care. Our team is, on the inpatient team, we're pretty close. We're a small group, and we talk it out. We talk a lot. We try to have lunch together. We debrief about certain patients that may have affected each of us a little differently. So I think we're all in this together, and we're all individuals, and we have to process it in the best way we know how. But I'm with Kara. Taking that PTO is super important, and just to get a break from it.
Yes to that. And there were several audience members who were saying yes to that. They heartily agree. I'm going to do that thing that interviewers do to panels every so often, kind of a flash. This will probably be our last round question of a particular, this was a question that was submitted prior to the webinar, a particular resource or book that if someone was really wanting to learn more about what is hospice, what is palliative care. So this is kind of your top 10 best, most formative reads in, like I said, whatever form, book or journal article. If you could each share those out, that would be a great way. And I promise this will be it. I'll let you off the hook after this.
I have to get my phone. I got them on my phone.
I got them on the phone too. I can't remember. Well, there's a really good Simpson handbook that we gave to all of our NPs recently.
Yes, that is very good. I have that one.
Which I cannot remember what it is right now, but we got it for all of our NPs. One book. So I remember reading a Tolstoy book in high school, and I could not get through it. I tried multiple times in my life, and so sometimes some of the physicians get together and try to read a book. And one of my colleagues, Dr. Webbright, mentioned the death of Ivan Ilyich, if I'm pronouncing that correctly. It's a Tolstoy book. And the good thing about this Tolstoy is that it was really thin, that it kind of looked a little boring. It had the cover was all gray and black. And I was actually reading it at the beach once in my parents' room when they were at the beach with us. And it was actually a really wonderful read. I kind of got sucked into it and read it in a day. And it really, even though it was set way back when, it really describes palliative medicine as a whole, kind of the denial, the family members trying to kind of deny the symptoms or not wanting to depress about talking about end of life. And so that's one that I will recommend even to non-Tolstoy lovers.
Excellent.
I'm going to say Atul Gawande's book, Being Mortal, is for a good read. But then, as far as in practice, it's very simple, but the Gone From My Sight, which was written by a nurse that we give out. We buy those and give those out to palliative and hospice families. And I think those are just incredibly invaluable. What is it, 5 or 6 pages? And that's an incredible clinical tool.
It's interesting. We used to do a little mini book club at St. Francis, where I was one of the palliative providers, and that was run by Melissa, our social worker. Now, there are some people that are listening right now that wouldn't read the books, but they'd show up for the fun part. But anyway, so we read a lot of different things. But I will say, if you ever get a chance to read 5 Days at Memorial, which talks about the flooding after the hurricane in New Orleans, and about what those providers went through and the patients went through. Not that this was as bad as that, but it kind of brings into reality that things that can happen and how we respond and grit and being able to kind of hang in there when things are really, really difficult. And I'm hoping it doesn't come to that this winter, but it is a great read. It's a little bit long, unfortunately, but it is a good read.
Mm-hmm. Thank you all. I might keep that question going forward. I like that. You all came up with really lovely and a variety of responses. The folks, participants are saying, were you trying to think of the book called Hospice and Palliative Medicine Handbook by Bodke and Ligon? Yeah, okay. One of your friends in the audience is giving you a phone-in help there. So yeah, it's called Hospice and Palliative Medicine Handbook, Clinical Guide.
It's very up to date. It's actually a good read too. So I highly recommend that one for kind of keeping at your bedside when you're on call.
And it's really concrete. It's very, very the way it's laid out.
Excellent. Thank you. And just fans of When Breath Becomes Air are chiming in right now. Paul Kalanithi's lovely book too. So yeah, it sounds like maybe your book club needs to be revived. Yeah. Well, we are at about time. And so again, thank you on behalf of the Supportive Care Coalition and all of you who attended today. Thank you so much for bringing your energy and insight. Thank you to our participants for being so engaged. As the webinar closes, you will see coming up on your screen a survey where we collect feedback about this webinar. And if you could just take a moment or two to fill it out, we actually look at that feedback and we can share it with you all, our presenters, if you'd like, and we use it to plan future webinars. Coming up, save the date for our next webinar. It will be on September 22nd. It won't be part of this series, but it will be a special hour-and-a-half long webinar. For those of you who remember Dr. Kevin Murphy, he presented for the coalition many months back now in COVID time. It's hard to keep track of time, but he did an excellent, very popular session on coding and billing. He will be coming back, and this webinar will be on palliative care program financial stability in the post-COVID landscape. Again, an hour-and-a-half long with Dr. Kevin Murphy, a real expert in this whole land of billing and coding. So please make sure and join us on September 22nd for that. Today's webinar was recorded, and you will receive an email tomorrow with access to the recording to listen to on demand. Thank you, Kara and Mark and Anne, and thank you to all our participants. Everyone stay safe and take good care.
Thank you.
Thank you.
Thank you.
Thank you.